Yeah, good afternoon, good morning, or good evening, depending on from where you are joining us today. Welcome to the LSTM In Conversation webinar. I'm very pleased to host this event today, and I'm very delighted that we have two great guests joining us, who I will introduce in a sec. First of all, I think it's a nice opportunity to reiterate that our alumni, staff, students, partners of LSTM have played, and they actually continue to play a really important role in shaping global health. And this webinar is an instrument to really underscore how proud we are to celebrate the power of the LSTM community, as it remains an active and influential voice in the global health conversation. So I will probably start by introducing myself. So I'm hosting this event today. My name is Christine Goffinet. I'm chair in virology at LSTM. Joined LSTM and UK 1.5 years ago. My team is highly interested in understanding the virus-host interaction at the cellular level. We focus on emerging viruses, but also HIV-1. We are very much interested in approaches to further develop the still non-existent HIV-1 cure strategies, and we also like to look at humoral and innate immune responses in the context of human pathogenic infection. So you already understand I'm very much at the start of the translational pipeline, conducting fundamental research, which hopefully will then feed into the translational pipeline. So our two great guests today, I'm now introducing them. I will start by Dr. Barry Atkinson, who is a lead environmental virologist for the Biosafety group at UKHSA, UK Health Security Agency. So you spent more than 2 decades researching on high consequence human pathogens, and actually you just gave a brilliant seminar, a wide ride through the history of high consequence human diseases in UK, which was really highly interesting and thought-provoking. So your expertise is predominantly in virus surveillance, detection, identification of known but also new infectious agents, including assay development, microbiology, high containment microbiology, and actually assisting outbreak response activities on the ground. So we are very happy to have you here, and you will be given a couple of minutes right after my introduction to introduce yourself and maybe start talking about your work at UKHSA. Our second guest is Professor Giri Rajahram. Happy to have you. An infectious disease consultant and a global health practitioner with the Ministry of Health Malaysia. So you are now really on the ground. You work as a practitioner. We are very, very curious to hear your insights, how actually findings can be really implemented in populations which are directly affected and who need it most. So you're a clinician researcher in infectious disease, tropical and HIV medicine in the Ministry of Health Malaysia, and you're providing innovative service care delivery for patients and empowering healthcare personnel with health ecosystems. So I noted you are an LSTM alumnus, so you performed the DTM&H diploma in 2017, and you are now an adjunct associate professor at Monash University in Malaysia since quite recently, actually, just a year or so. So very happy to have both of you here. And I'll hand over maybe first to Barry. Would you like to introduce yourself and start talking about your work and start the conversation?
Okay, thank you, Christine. Yeah, you covered a lot of my focus there. So at the moment, I lead a team that can perform environmental sampling when cases of infectious disease are detected in the UK, and we wish to learn more about transmission risk, onward transmission to other people. There's a huge focus on these high consequence infectious diseases, but we've done a lot of work over the years with other pathogens, SARS coronavirus 2. We've even done bacterial pathogens such as Bacillus anthracis in the past. It's when these events occur, it's to go in learn more information to inform infection prevention and control measures, because this could help prevent onward transmission to others and control this public health response. I think that will summarize my work. Don't want to take up all of the time.
Thanks. Giri, I hand over to you.
Thank you very much, Professor. My name is Giri Rajahram, infectious disease clinician, mainly to begin with, and a very proud alumni of LSTM. I think it's truly an honor to be back, at least in this webinar, in the space to speak about the experiences I've had and how fundamentally transformative my time at LSTM was in pursuing a career in infectious diseases. So a clinician on the ground most of the time, but also a clinician researcher, particularly in emerging threats of zoonotic malaria in the context of Malaysia and Southeast Asia. So Plasmodium noza is a hotspot within Borneo in particular. And I helped a lot of work in translating some of the clinical findings that we got to policy responses within the context of Ministry of Health in Malaysia. And also probably more internationally in the global within WHO policy guidance for noza and malaria. So happy to be here and happy to share thoughts and insights, and obviously for the people on the webinar as well to reflect and discuss on infectious diseases in particular. Thank you very much. Over to you.
Thanks. I realize we are an interesting group today because we really cover very different aspects of global health research, covering fundamental research to understand how new viruses work, surveillance, direct response to new infections, and covering also the healthcare, the medical care of affected patients and populations. I'm really looking forward to hear your thoughts about different aspects. I forgot one thing before I started the introduction round. To everyone who is listening to us, if you have questions, please put them in the Q&A section, and we will spend the last 10 or 15 minutes or so by trying to address some of these questions, depending on the time remaining. I forgot to mention that. Great. If we start thinking about global health research, and we are infectious disease lovers here in terms of scientific interest, the first question that I would like to propose maybe to chat on would be how to respond to new infectious diseases early and efficiently. So I'm just looked up these numbers of this really mystery outbreak in the Kwango province in DRC, which happened at the end of last year. I'm sure you heard of it. I just looked up the number of cases. So by December, there were 406 cases of mostly children actually affected by heavy respiratory symptoms. And among these 406 cases, 31 deaths, mainly in young children. People have started naming this as disease X, which is an established term. And yeah, it was a very spooky situation because it seems to have been in a very remote area of the country, which is known to have association with malnutrition. And later, when some lab investigations started, they found a high incidence of malaria. So I think, and I would be really curious to hear your thoughts about this, we ended up in a situation, having an outbreak situation with an unclear etiology, or maybe it's not even a single one, maybe a mixture of circumstances. And this outbreak, as many others, but this was really a textbook example to really illustrate how difficult it is to actually handle this on so many layers. It's very complex. It starts with logistics, societal aspects, but also the mere organization to get to the site, to sample the right samples, to do the right diagnostics. So in an ideal world, how would such an outbreak containment, or even earlier, the identification of the corresponding agent work ideally? Maybe, Giri, I hand over to you because you're, a practitioner very close to the people experiencing these kind of diseases. What are your thoughts about how this could be managed ideally? Where do you see the gaps if you look at real life situations like this outbreak?
Okay, thank you very much for the question. And it does pose a challenge. And I will share it from a perspective of being a clinician in Sabah, Borneo, and relative to upper middle income country Malaysia. There is slight, contextual differences when it comes to Borneo and it comes to Sabah in particular. And I would like to leverage on taking a COVID-19 as an example. And we ask ourselves, what lessons have we learned? And it's often said that diseases are a failure of prevention, and hence contextually both for communicable diseases and non-communicable diseases as well. So, from a context of disease surveillance itself, many places that includes countries like Malaysia and Sabah, Borneo, we always would like to strengthen surveillance system. And many a times formal surveillance systems are based within hospitals and health facilities. And this sometimes, although good in the formal process, it might not be the best when you want to detect outbreaks or spillovers in rural communities. And sort of, if you look at a bigger, larger framework, contextualizing what the context is in the particular country, and getting informal based surveillance and intelligence within communities itself. For example, traditional faith practitioners, religious leaders, and also smaller health-based facilities. When you see cases of syndromic conditions, for example, a respiratory syndromic condition or a central nervous system syndromic condition of a cluster of cases, identifying them and sort of getting them up the chain of response. I think that's important and embedding, particularly in large rural-based communities, and that's an example based in even in Sabah as well, where we try to get village leaders and faith practitioners when they see conditions or syndromic conditions that fit in a cluster, to sort of report them to the local health practitioner so it can go up the chain of command. That's one. And if you look at the COVID-19 condition itself, what we learned is centralized testing and diagnostics perhaps is not the best when it comes to rapidly responding to a new pathogen. And that, I think, we learned pretty fast. And in the context of Sabah, we had to sort of decentralize response for testing and diagnostics, where we had translated small mini hubs of labs within districts to the East Coast and the West Coast, which were capable of doing diagnostics and PCR. And this facility now translates to, for example, capacity within these communities to have PCR testing available in case of a new emerging pathogen rapidly for diagnostics and pathogen recognition. So I'll leave it at those two examples, and I'll hand it back to you. And happy to have a discussion on this going forward.
Thanks. I understand from your response that, and I would agree with you, that there's no one approach that fits for all, but there needs to be an individualized approach for each country or even countryside or part of the nation, which really takes under consideration all the specific aspects of the local situation. And yeah, and I agree with your suggestion to decentralize testing, surveillance. I think you are entirely right. The COVID-19 pandemic has really shown this, that a very centralized approach has more disadvantages than advantages. Barry, what are your thoughts on this aspect?
Yeah, there's a lot that Giri mentioned that sprung to my mind as well. I think surveillance is obviously critical when it comes to having an early response. It could be zoonotic surveillance as a early warning to what might be coming, but we also absolutely need good syndromic surveillance to understand what is causing the clinical cases that we're seeing. And then communication, it's really important. We need a widespread communication network, so global, getting viewpoints from people around the world. But the important thing that's already been mentioned, this needs to have a local focus as well. We saw with the Ebola response that the way that Western countries believe that a response should be led does not necessarily match with local customs and traditions, and if they're not synchronized, then we're only going to be causing problems as we try and deal with a problem. So those are two big things that jump to my mind. I think we all know we need to move away from parachute science, having people come into a country thinking that they can provide the answers to what is going on. And certainly long term, we need to be capacity and capability building. All countries around the world are at risk for a new disease emerging. When we get new technologies that can assist with early response, we need to get these on the ground early, rather than bringing them with us when we try and deal with something that is reported. But yeah, I think it's a lot of the same things that have already been discussed.
Right, and you mentioned the zoonotic surveillance, which of course opens an entirely new area, and we know that many of these high consequence infections, or human pathogenic infections in general, many of them have a zoonotic origin, which means that we should invest much more and not only looking out for sick human patients, but also to monitor, to have some sentinel systems in animal populations, which of course is very tedious, but probably the only way to alert ourselves really early. I cannot resist to mention now, how do you interpret the problem introduced by the change in the US government administration? They have funded a large part of these activities in many countries in this world. And I've spoken to some partners on the African continent, and many of these activities are stalled or even endangered to continue in total. Does this affect your work at some part of your partners? Do you have a first idea how the current situation, what this could mean for surveillance work in terms of human disease at the level of patients, but also in the animal populations?
I think it's too early to make any definitive statements on that. I think we're all in the same boat here. We're watching what is going on in America and seeing how it affects different people, and then we just have to try and respond to that. All we're doing at the moment is trying to make sure we are as resilient as possible and as prepared as possible. And with each new piece of information that comes through, whether that's relating to the pathogen or relating to politics, we just have to respond in the best way we can.
Yeah, I even heard people saying, maybe as sad as this is, but this is maybe now the opportunity to change our own priorities, each country on its own, and decide to shift gears regarding where to invest for research in these kind of surveillance activities, and to actually take over some responsibility. I was a bit skeptical when I heard this, because this has still to work out. I mean, yeah, the future is going to tell us. Giri, what do you think? Is your work affected by these recent changes?
I completely echo Dr. Barry's sentiments on this. As we hear the feeds of news coming through, I think there's a bit of, we're all a bit perplexed on what exactly might happen. And sometimes what is suggested might not translate to what actually is being. But I think for all intents and purposes, if it push comes to shove and it becomes what that has been suggested, I would imagine there would be impact and work significantly in many parts of the world. But as you mentioned, therein lies an opportunity to shape the narrative, perhaps on how we would like to move forward and how we would like to see research being done within capacities locally, and hopefully more sustainably moving forward. But again, it's all far too early, and I'm sure there'll be lots of disruption if it comes to what it is. I'm sure many researchers around the world are keeping their fingers crossed and hopefully putting in preparations to mitigate as much as possible the impact if it comes to what it is.
Right. I hope the global leaders are listening to us and taking wise decisions. I would like to come back to my outbreak example, which we started talking about. And I was asking myself, specifically, what are good strategies in general, not only in this outbreak situation, how to identify the causative agent in an unclear situation. And AI, sophisticated metagenomic analysis, transcriptomic analysis, are being discussed more and more, but there's still a kind of hesitancy, I would say, if it comes to AI, to really use these new developments in the term or in the context of global health. And yeah, I would be really curious to hear your thoughts. Are you using AI in your own work? Do you plan to use it? Or if you already use it, can you give us a couple of examples where you think artificial intelligence really revolutionizes the speed or the quality of the findings, maybe, and where are the potential risks or dangers of using this new technology? So my own lab does not use AI at this moment, but we perceive more and more that we are missing an opportunity. And I think, like as 30 or 40 years ago, people were learning how to do PCRs. Now we have to learn how to use AI. So what's the current state in your teams and in your work? Giri, start with you.
Thank you. I think there's lots of enthusiasm and excitement with the capacities of AI. I think within country context here, there's still a lot to be learned. And I know sometimes AI, the promise and the translation to it might not necessarily happen within the same time frame. And in the context like Sabah Borneo, using and leveraging it, although important, perhaps is still limited by expertise, local expertise, the infrastructure availability, and also the cost containment when leveraging on these features. Although we use a lot of genomics, for example, for diagnostic, for disease surveillance, and also for tracking antimicrobial resistance, increasingly, AI is sort of not mainstream in the context of use within health facilities. It's still embedded in a lot of research settings. And the experience perhaps on the ground is not as fluid as what we experience within labs and research settings. I'm sort of brought aware of some of the nuances when using AI, for example. There's obviously a lot of promise for predictive models, for example, integrating climate and weather responses to predict dengue outbreaks within the context of Malaysia, which we have an application as such, which is also used in the public health system. So those are the examples which we have used. Still very limited, but I assume and I imagine it's going to be increasingly even more within the context of work. And as people and, for example, frontline practitioners become more comfortable with the technology and the nuances which it brings, it probably be widespread. I think it's not a matter of if, it's when, and the lag time between some countries might be different, and hopefully bridging this inequality of taking up the science is consonant within most people and globally. And as you speak, there's the AI summit happening in Paris, and there's a lot of nuances in and inward-looking sort of trajectories in many of the leaders within the tech industry as well. Hopefully, looking at what this capacity of AI has and how it can be leveraged for the good of all of us.
Is AI already, thanks, is AI already part of our current students' curriculum? Is this already sufficiently covered? And I actually don't know. I would suspect it's still in its infancies regarding teaching students what you can achieve with AI. Maybe this is a large gap that needs to be addressed very soon. Barry, what do you think?
Yeah, so within my team, no, we're not using it at the moment, but obviously I'm just one part of a very large organization, and I know that throughout the organization, people are starting to explore how AI can help advance what we do, and a number of my collaborators are exploring this avenue. For me, I think AI is perfect for science, right? It gives you a hypothesis, and we're scientists, right? Our job is to find data that supports or refutes a hypothesis. So giving some of the problems we have to AI and seeing what it thinks, it's just almost highlighting the most likely hypothesis. So I'm very excited to see where this goes. I think the scenario that you raised with an outbreak of an unknown pathogen is a very interesting one. I think that AI, again, is fine to drive a hypothesis, but I think when we've got an unknown pathogen causing disease, the response probably needs to be what it has been for the last several decades, which is treat this as a multidisciplinary response. That it's fine to have our most likely suspect, but we have to go in with multiple technologies and allow data to show us what the answer is here. That, I'm sure we all read ProMed when we get the request for information, and we all think, oh, I think it's this. That can bias how we respond. We have to do all the necessary tests and cover all necessary bases to respond to public health situations. So that's maybe where AI may lead us astray, is by funneling us down one avenue when actual fact that the answer is something else. But as long as we treat it with the same way that we have with all new technologies, I think it's only going to help us.
Mm-hmm. Maybe it's a good opportunity to highlight one paper which caught my attention, where AI has been used to design totally novel proteins that neutralize lethal snake venom toxins. It's a Nature paper which came out a couple of days ago. LSTM has also been involved in this. So maybe the future of AI is more in drug development, rather than maybe diagnostics. Maybe I'm saying something wrong. I don't know, but I think it's clearly underexplored, the power of artificial intelligence in the design of novel treatment strategies, maybe. So you also talked about genomics and sequencing. So how often actually does it happen that you have a sick patient in front of you and genomics won't help you to identify the agent? Because I know of these cases where people just have some illnesses, there's no diagnosis, and clinicians attempt to sequence biological samples, but sometimes this is not conclusive. So do you have any experience in this context? Giri, maybe start with you.
So as we speak, locally, we in Southeast Asia, at least, we're just setting up a network within Southeast Asia, looking at syndromic respiratory illnesses as part of a prepare network. Obviously, patients will come through with pneumonia to begin with, who've gone through the normal panel of respiratory tests and which have no diagnostics. Eventually, the plan is to sort of sequence them and see what they might have. Now, obviously, it's part of embedding it in the research setting, and it's the whole idea is to sort of have this warm network. If and when a pandemic happens, there is a network ready to sort of run. But going back to your point, running next generation sequencing for individual cases, perhaps is from a context like us, not cost effective. It wouldn't be sort of in a context of routine care, but it's going to be probably batched, kept, and run as part of research. When it translates directly to care in real time, perhaps not, but hopefully it suggests what we might not be seeing in routine diagnostics that we have, and be an impetus for developing and also getting policymakers to think about bringing in newer diagnostics for pathogens we might have, which we're just not diagnosing at the moment. Over.
Thanks. Barry, your opinions on the power of sequencing in unclear cases?
Yeah, so I mean, obviously, I have a research focus, but not just within UK HSA, but with other centres. I know people that are on the diagnostic front line, and I think most of the world is going down the road of seeing just how far metagenomic sequencing can help us. One thing I would say is we've got to remember Koch's postulates that just finding a sequence in a sample does not necessarily mean that it is the causative agent. So that's one potential pitfall that we might have with metagenomics. But I mean it's such a powerful tool that I think we're all hoping that this is going to really advance this, especially when we get these seriously ill people with such severe clinical manifestations and they test negative for all the usual suspects. Those are the cases I think that we want answers to, but we just need to remember the pitfalls that are around us when we use this technology.
Yeah, thanks. And another challenge maybe that comes to my mind is the whole complex of climate change, which I think gives us another layer of complexity when we think about global health now compared to maybe 50 years ago. So what do you think, how is climate change going to influence global health in general, but also regarding our research priorities? Or does climate change have a direct impact on your work of you both, which you are trying more and more to consider? So how do you work with this changing situation in your professional life? Giri.
Yeah, I mean, being in Southeast Asia, we just can't run away from it. It's just a reality that climate change, how it affects. And I use the example of malaria, which we see here, which is very climate sensitive because of humidity, rainfall, rising temperatures, and whatnot, and how you see expansion of the geographical vector capacity, which previously were not seen, and how, for example, the life cycles of the vectors also have changed in the behavior patterns, and case spread within the context of where we are as well, which is affected by the changes in the climate. And then, of course, because of prolonged droughts and humid rains and cyclones and whatnot, waterborne diseases, for example, cholera, leptospirosis, and melioidosis, which we see more often after floods. And that's, something we have to be very aware of being in this region. And how do we tackle them? Obviously, it needs a whole of government response. It's not sort of in silo a medical response per se. It's urban planning. It's development. It's bringing local councils through in sort of building, mitigating facilities within the context itself, and also building in this climate sensitive patterns to public health surveillance and response for example, predictive models where you might have a next dengue hotspot or a malaria hotspot, integrating rainfall patterns, how humidity has changed, and how the vectors have behaved differently. And going back to the One Health approach, and we all, I'm sure most people here are aware of, most emerging infectious diseases are zoonotic spillovers, on how we bring together different partners within wildlife, within veterinary services, within climate ecologists, public health scientists, in realizing and knowing what is out there to begin with, and when that jump has happened, based on embedding a syndromic-based surveillance within health facilities and health responses. So I'll leave it at that, and I'll pass it over back to you.
Yeah, I like that you mentioned the interdisciplinary aspect, that we require very different and many disciplines and expertise to tackle this. And I wonder whether this is sufficiently covered, or we still tend to think and work in our own silos, and actually this entire problem would so much benefit from more interaction between different expertise. I first hand over to Barry. What are your thoughts about climate change? How does it impact your work now or in the future? Which changes do you anticipate?
Yeah, so I think climate change is probably, I mean, I consider myself to be 20 years into my career. I'd say that climate change has been omnipresent throughout that. One of the first pathogens that I started working on was Crimean Congo hemorrhagic fever. When I started, in terms of Europe, it was only some southern eastern countries, Greece and Bulgaria, that were considered to be endemic for CCHF. And you look in 2025, we've added Portugal, Spain, France to the list. It's the same pattern we see, that first you start detecting the virus in the ticks, and then you start seeing human cases. It's a predictable pattern. So as our climate changes, we're going to see more and more countries become endemic. It's how we respond to what is almost inevitably going to happen. And that's just one pathogen. The same pattern has happened for West Nile, for chikungunya. We're getting autochthonous cases in countries that were not considered endemic before. So, yeah, I think that it's almost something that I don't think is a new threat based on what my specific focus has been. This has been something that's been drilled into us for a while. I don't think you need to convince many scientists, infectious disease researchers, that climate change is a future problem. I think we all think it's a now problem, and that's why we need to focus on things like surveillance, the early warning signs, not waiting for that human case to emerge to confirm our suspicions. It's to get the background data before that first human case emerges to make us aware in advance. But yeah, I don't think I'm telling anyone anything here that we're not already aware of. It's definitely a problem, and you mentioned what we need to be doing. It's interdisciplinary approach. It's not waiting. It's to get all the parts of the machine up and running in advance.
Right. I think there's another aspect which comes to my mind when I think about global change or climate change, is that not only the quantity of infections will probably change, but also the quantity of co-exposures, of co-infections, because vectors which were previously very confined to specific regions on the world now have evolved to actually be totally fine in other areas, and now they're finding, first of all, immunonaive populations regarding the viruses or the pathogens they transmit, but they also mix up with other vectors, with other infectious agents. And this can, I mean, you know better than me probably, but I imagine that this area of research is a bit understudied, because everyone likes to focus, on a specific pathogen inducing a specific disease. But do we face enough the problem of people undergoing multiple infections at the same time or subsequently in small intervals? I think this is a bit underexplored, but again, like to hear your thoughts. Giri, please.
Yeah, from a clinical perspective, obviously, we sort of would like to, from a clinical perspective, Occam's razor, where you like to explain most things within the most simplified way. And as you correctly pointed out, increasingly, obviously, we're going to see co-infections. And if I just go back to the example of COVID-19, when you had to decide whether the patient had COVID-19 or the patient was just, having infection, another condition to begin with, but also happened to be infected with COVID-19. And it was very difficult to discern because sometimes there was overlapping presentations, and you had a clinical diagnosis on whether it was COVID-19 or was something else, and the patient was just a bystander for COVID-19 per se.
Mhm.
So using that as an example, and as you mentioned, the increasing geographical range of vectors carrying diseases, we will see diseases which happen and co-infect. And if I use an example here in Borneo, we see patients occasionally with both dengue and malaria. Not a common thing because they're two different mosquito vectors, but occasionally, surgically and clinically, they behave as such, and you have to treat it as such. Now, has it been studied enough? I do not think so, at least from a context of these two bugs that I'm speaking about. Will it be a challenge moving forward? Yes, because of climate and because of the expansion of geographical vectors. And as you suggested, perhaps there should be teams, perhaps both locally and regionally, looking at this in more detail.
Barry, anything to add to these thoughts?
Yeah, I think it's a fascinating topic. Again, we're limited by our own technology. If we see someone sick and we identify a pathogen which could be responsible for that, it's an easy tick, but we don't know other contributing factors, other co-infections, anything that might be suppressing their immune response. But there's also the same questions in nature, when we get co-circulation of viruses within the same, let's say, vector. I was always fascinated with the story of Ungari virus, which is, it's a reassortant of two bunya viruses, Batai virus and Bunyawera virus, and neither of the donor viruses were particularly pathogenic to humans, but this reassortant virus resulted in hemorrhagic fever. And we were lucky that Ungari virus has not been seen much in nature since then, but it goes to show us that these events do occur. Pathogens do not respect borders. You will get these unusual events occurring, and it can have unpredictable outcomes.
Right. So I'm sure there's also maybe persons listening to us who might think about studying something which relates to global health, or early career researchers who think about the direction of their future career. What should we let them know? I think I would like to let them know that this is a really fascinating field of increasing relevance and increasing importance, and that we really need all hands on deck to really tackle global health in the context of the ongoing climate change. Is there anything you would like to add? How can we convince young people to work in this field, to study something related to that, and really help to combat all the challenges associated to that? Do we have a message to them? Giri.
All right. I'm just gonna, put my younger self hat on and sort of try to reflect, how infectious disease came about. As a med student, I never wanted to do infectious disease, or at least I never had an interest to do infectious diseases. And I must say, I always thought I was going to be a neurologist, because I just loved how the body worked. But being a young doctor, training in Borneo, working in Borneo, you saw how communicable diseases firsthand sort of affected communities, and how it brought a lot of pain and suffering to people. And the most rewarding part in the context of large infectious diseases we see, if you have readily available therapies and readily available treatments figured out, patients respond and get better very fast. And sort of my young idealistic self looked at that and said, look, I think this is something exciting. It gives the opportunity to study something unique, and also perhaps gives you the opportunity to give back to the communities that you sort of worked with. That's the young idealistic self. And as you sort of work and train and become a clinician, you realize the contributing factors to ill health is just not a particular bug or a particular pathogen. It's more than that. There's social determinants to health, there's the political determinants to health, there's the sort of commercial determinants to health, and you see your role evolving and changing over time. Perhaps advocating, trying to translate what you studied from research into policies, and also nudging the right people to make the right decisions, perhaps at local government, regional, and national level. What I'm trying to say is, at the end of the day, is it evolves probably over time. Finding your passion might take time. It might be early for some, it might be later for others. It's following your heart. And as Steve Jobs said, just follow your heart, because somehow it knows what it really wants. And sometimes closing that whole loop might be trying different things over a period of time before you realize what you're meant to do. And it's probably not a straight line to what you eventually do. I don't know if I've helped there, but I'm just trying to give a context on how I sort of came through what I came to do. And I just wish the very best of luck to everyone here.
That's very well phrased. Barry, do you share the enthusiasm?
Absolutely. And I consider myself very fortunate, because I became passionate about viruses and high consequence viruses when I was in secondary school, about to go into further education. It was the perfect time. And there's an old adage that if you do the job you love, you never work a day in your life. And it is so true. I don't think I've ever had a day where I've woken up and gone, I don't want to go into work today. And what I'd be saying to young people is, if you've got a passion for this is such a great area, because the book is still being written on infectious diseases. We're centuries into it. We've got centuries left to go. We're still learning each and every day. So if you've got a passion for advancing our knowledge and understanding, it's just the perfect field to do it.
Right, and I hope that this topic is not only seen as the dangerous, looming topic which is causing a lot of worries, which is, of course, but I think the approach to work on this and to contribute with different expertise is really fascinating and very rewarding. So I'm 100% with your statements. Well, that was very insightful and thought-provoking. Thanks a lot for having this discussion with me. We have a couple of questions in the chat, so maybe we can dedicate the last few minutes of this event to maybe talk about those. So someone asked, Kennedy Wadia asked the following question. No, it's more a comment than a question, actually. Microbes seem to be developing resistance to antimicrobials faster than we are able to develop antimicrobials. I would like to get your thoughts on this trend. AMR is a slow-moving pandemic at the moment. Yes, I acknowledge we have been a bit virus heavy in this event, and we have not talked a lot about AMR and resistance in microbes, actually. We should do this now. Barry, do you have any comments on the pace of development of antibiotics Can you maybe explain what the challenges are and why this is actually so slow?
Well, you're right. The progress is slow. It's painfully slow. I think part of the problem was that as we developed an array of antibiotics, the assumption was that we'd got way ahead of the curve and had solved the problem. As to why the pace hasn't picked up in the last decade or so, I'm not in a position to comment. I'm not an expert on that. But this is perhaps an area that AI can help get us back up to speed, because we have fallen behind. I don't think there's anyone listening to this is unaware of how big a problem AMR is. But maybe AI is something that can help us get back to the place we need to be, because it's clear we're not there at the moment.
Thanks. Giri, what role does AMR play in the patients you are seeing? Do you also see this increased relevance and incidence?
Yeah, I would say AMR it's more of an unseen and a silent pandemic. It's a pandemic. I think it's in the background on many people's mind. If you're a frontline clinician, you would see patients who are resistant to all antimicrobial therapies that you have. And from a Southeast Asian context, we have a network looking at pathogens that cause hospital-acquired pneumonias and bloodstream infections in hospital. And within a Southeast Asian context, most of them are either drug resistant or multi-drug resistant. So there is a huge problem. There's an economic toll to it. There's a mortality toll to it. There's a morbidity toll to the patients to it. To the question on why the antibiotic pipeline it's sort of slowed down. I think historically there always the incentivization on how development of drugs when it came to pharmaceutical companies were because you had to invest heavily early on front loading and the sort of buyout coming through at the end of product development, it's probably slightly less. That was the historical context to drug development. I think increasingly different models of incentivizing development has come along. You're looking at private-public partnership in developing antimicrobials. And as Barry pointed out, perhaps here is one area where AI can be leveraged, for example, for new compound discovery and translating them from lab to clinical science. So drug development has been slow. That's number one. Even the ones that have been developed and available, getting it accessible to countries which most need them, perhaps it's beyond reach because of the cost of a lot of these newer antimicrobials. And number three is judiciously using them. You have a new compound which have which probably has a limited lifespan when you're going to use it. You really want clinicians on the ground to use it judiciously, and balancing that act within those three parameters is probably a complex thing.
Right, and I think it's probably also true that the incentives for industry are apparently not pronounced enough, and it really needs more engagement from the WHO or NGOs or from governments to actually invest in this area, or to at least initiate some meaningful research and to really fuel the pipeline to develop new antibiotics, for example. But yeah, I really agree. This is causing a lot of concern. There's another question, a bit different, asking, is there a role for private philanthropy as opposed to research funding in supporting innovations in infectious disease research and care? And if so, how do we influence these funders? Giri, how do we exert, or how could we lobby better?
I think that's a whole wide area of sort of discussion on prioritizing funding for areas which we probably might be more niche. Traditionally, again, I think philanthropic funders have had focus areas which they would like to focus or research on, and that's partly translated to sort of academic centers sort of leveraging on this interest from philanthropic institutions. And again, is sort of navigating that conversation to areas which are probably less niche, less seen or less researched. How do we do them? I think there needs to be a whole conversation to it. You don't have an answer by in itself on how we sort of change that trajectory of influence, because I think a lot of centers and a lot of us within clinical research live on grant cycles to grant cycles, and because of that, your research area becomes focused and niche to a particular disease or particular pathogen. Now, who leads and who drives probably a more outward-looking focus on what should be studied. Should it be organization like WHO, which has come together for many different conditions, many different responses. For example, vaccine development with CEPI, for example, has sort of driven that kind of influence to look at a pathogen, a new pathogen, and a 100-day response to a new pathogen. So those are conversations at a much higher level, and obviously taking into a contextual focus on what pathogen we're speaking about, and stakeholders being the communities which we are studying in, and what they see success, and from funders' perspective, rather than funders on what they try to influence and leverage on.
Barry, anything to add?
I think the main points have been covered. There are private philanthropic organisations out there. We'd hope there'd be more as well. The key and the message that I would try and get across to young scientists is that the future is going to be science communication. I don't think we've had as big an evolution in science communication as we have had in science. How we get our message across to the general public and to potential funders of the importance of the work that we want to do, that is something which I think will improve in years to come with the more tech-savvy generations coming through. And maybe it's that interface from the scientists to the funders that the biggest change will happen in the coming years.
Yeah, I agree. We have one final question. If we are quick, we can maybe manage it. So I will ask you to respond with 3 words. So the question is, what are the most promising research areas that could significantly improve our preparedness and response to future pandemics? So I will start to give you a few seconds to think. I would say the most promising research areas would be to conduct, so the first one, fundamental research on the biology of the causing agents to understand interaction of the pathogen with the host. I think implementation science is the other end. So to actually transform strategies that have been developed to something that is really applicable in real life. And the whole aspect of pandemic preparedness, focusing on zoonotic sources, I think is very exciting and promising research areas in this context. What are your 3 keywords? Giri, I'll start with you.
Yeah, I mean, very clinical focused, emerging syndromic-based surveillance. It looks fairly straightforward and simple, but having it embedded within health facilities, contextually within countries, it's important. Number 2, diagnostics and therapeutics. When you have an emerging disease, what works and what doesn't work, knowing them fast is important. And, COVID-19 was a good example on, how things which did not work was used and how things which was working came on a little later on, but good research was done. And third is vaccines and vaccine development. And I totally agree with you. Implementation science, having all this knowledge, translating them to communities we work with, perhaps is most fundamental after having all of this available. Over.
Barry, you have the final words.
Yeah. Okay, so I'd say number one would be collaboration. There's no institute, no agency, no organization that can do things on their own. Number two, communication. We've got to when we find things out, we've got to share it with others, because there'll be people who will pick up more niche things than we're looking at. And number three is data generation. That has to be the foundation for everything we do. So maybe I did them in the wrong order. Maybe it's data generation, collaboration, communication. That's probably the better way of phrasing it.
Excellent. Thank you so much. I think this was a perfect question to wrap up this really interesting webinar. Thanks to both of you. You were fantastic guests. I really enjoyed the conversation and the chat with you. Also, we would like to thank everyone who joined us today. And we hope you will join the next one, which is coming soon, the next LSTM In Conversation. And I'm also supposed to let everyone know that the recording is going to be made available for everyone who joined today. And of course, you are very welcome to share the recording with whoever you think would be interested. So again, thanks a lot, Giri and Barry, for your insightful comments. And hope to see everyone at the next LSTM In Conversation event. Bye.
Thank you.
Very much. Bye-bye.
Bye.